Welcome to eAJKD's first video blog, and we're here with Dr. Ilya Glezerman and Dr. Surya Seshan. Dr. Ilya Glezerman is a nephrologist at Sloan Kettering and the Renal Education Director for the Fellows at Sloan Kettering. Dr. Surya Seshan is a professor of pathology and chief of renal pathology at Weill Cornell Medical Center. We're here talking about your recent publication titled Kidney Tubular Toxicity of Maintenance Pemetrexed Therapy, which is a new chemotherapy agent. It seems like some form of renal toxicity has been described of this agent in the past. So what did your paper add to the literature?
I think there have been several case reports, isolated case reports of tubular toxicity related to Pemetrexed exposure. Also in clinical studies which were done prior to Pemetrexed coming on the market and being available. There have been some reports of acute kidney injury or acute renal failure, but most of the cases were reported as resolved. So we wanted to present something more in depth. Our cases are, first of all, it's a case series. We have 3 cases. All of them have kidney biopsies because prior to that, the case reports did not have the biopsy proven toxicity. And also our patients had various exposures, so we can actually see a spectrum of disease that can be caused by this agent related to time of exposure to them.
Yeah, these patients actually had much more prolonged exposure and to a higher doses. So we see tubular injury that is more subacute, entering a chronic stage at this time.
In terms of pathology, when I was reading these the paper, there were all these patients also had received some anti-VEGF agent, an anti-EGFR agent. How can you be sure the toxicity is not compounded by the prior toxicity of some of these already known renal toxic agents?
That's a good question. Actually, the EGFR agent generally has had no history or no documented paper in the literature to cause renal toxicity. With the anti-VEGF agent, it is generally glomerular disease that you see, and glomerular endothelial injury, ranging from mild to severe, that would end in thrombotic microangiopathy. Often these patients will have varying degrees of proteinuria as a result because of the altered permeability and even hypertension. So we don't see any glomerular disease at this point here, and not much has been documented in terms of tubular interstitial disease with anti-VEGF.
I think there were 1 or 2 cases of interstitial nephritis, I believe, has been reported with VEGF, but we didn't see a lot of interstitial nephritis in this particular case series. There have been another report from a different group that did report interstitial nephritis and acute tubular necrosis at the same time in the tissue, but not in our cases.
Okay. Can you elaborate a little bit on the mechanism of injury of this agent on the kidney that you were Dr. Seshan?
Well, we can mostly postulate as to what happens, but the tubular cells, particularly proximal tubular cells, have receptors that may take up Pemetrexed. These are folate receptors, but they also will take up Pemetrexed, and it's possible that this prolonged exposure to the drug and uptake has caused a particular concentration of this agent in the tubular tissue, and the subsequent toxicity. Another group, Dr. Stavropoulos, also had postulated with their case that it's possible that this is what happens. And in fact, there are transporters in both basolateral and tubular side, apical side of the proximal tube.
Yeah, the pathologic changes that we see as a result of whatever mechanism, they're quite non-specific, but we do see evidence for tubular cell injury, which is the culmination of a toxic effect to the cells, which you can see with a number of other chemotherapeutic agents as well. But it is the clinical association that would lead us to believe that this could be Pemetrexed.
It's always difficult to prove the toxicity of the drug because it's all sort of pathology similar to any other toxicity, but in our case, the time relationship between initiation of Pemetrexed and absence of other nephrotoxic agents sort of points towards this being an effective agent.
Have you seen more cases of this after this publication, or since you submitted this publication?
We have seen a few more cases. In fact, we're planning to probably maybe look at an incidence of this problem at our institution to look at the total exposure to pemetrexed, review the charts, and see if maybe there were some undetected cases. Pemetrexed usually stopped when the creatinine is elevated, and it's not recommended for patients with the creatinine clearance below 40 because of the retention and potential myelosuppression. So this may be the case that didn't come to our attention. That was just noted by oncologists. The medication was stopped and switched to something else, but we're going to try to review that.
ASN has been lately very interested in onconephrology, and it's been heavily discussed now at ASN last year and this year. It's probably something that is a growing field, and what are your thoughts on this novel branch of nephrology in terms of fellow training and just career advices for future nephrologists?
Well, I think it becomes a very prevalent problem, cancer and oncology, even for kidney doctors. If you look at databases, for example, Medicare patients have carry diagnosis of CKD, also carry about 18% of those patients also carry diagnosis of cancer. So it's obvious that 1 in 5 patients who are seeing nephrologists are going to be, going to carry some diagnosis of cancer. There are almost 11 million patients who carry diagnosis of cancer in the United States. We're going to be seeing a lot of these patients, and they all probably receive chemotherapy, and nephrologists need to be aware of potential nephrotoxic effects of it, and long-term survivorship is also growing, and we're going to be exposed to this potential long-term effects of nephrotoxicity.
Right, yes. These, I just want to echo what Dr. Glezerman said in terms of the quality of life for these cancer survivors. You don't want them to have CKD or go into renal failure and become more morbid as a result of that, rather than having a good quality of life. On the same token, the nephrologists who care for these patients, or the oncologists, have to monitor renal function in these patients. And at an appropriate time, a kidney biopsy will help them decide what type of disease is lurking in the kidneys. There are several groups of diseases that you can see in the kidneys. They can be unrelated kidney disease. They can be directly related to cancer, or paraneoplastic syndromes can affect the kidney. More importantly, we will find out whether there is a reversibility of these renal lesions, and can they be treated, or are they irreversible and chronic?
Well, thank you for your time, and congratulations on the publications. This is eAJKD. Thank you.
Thank you very much for having us.